Very good afternoon to all. So, at the outset, I would like to thank the Prerna ma'am and the organizers for giving me this opportunity. So, we'll start the program with the discussion on the management of drug sensitive and drug resistant TB. I'll be mainly concentrating on the treatment in adults. So, as Alok sir has pointed out in his initial talk, the global prevalence and incidence, if you look into it, you can see approximately 1/3 of TB patients, the incidence is in India. So the global burden of TB and especially the burden of TB in India is pretty high. So why do we really need to treat TB? What are the goal and objectives of treatment of TB? So it has mainly three objectives. That is to decrease the case fatality and morbidity by ensuring relapse-free cure. So minimize and prevent development of drug resistance and render the patient non-infectious. That is break the chain of transmission and decrease pool of infection. So the aim is to diagnose the TB at the early stage so that the patient has less morbidity and mortality, to treat them sufficiently so that there is no relapse and there is no drug resistance, and to break the chain of transmission, thereby decrease the incidence of TB. So whom should we suspect TB, or who is a presumptive pulmonary TB patient? So any person with any of the symptoms and signs suggestive of TB, which include cough for 2 weeks or more, fever for 2 weeks or more, significant weight loss, hemoptysis, or any abnormality in chest radiography, especially in high-risk people, that is non-contacts of microbiologically confirmed TB, people with HIV, uncontrolled diabetics, malnourished or malignancy patients, patient on any immunosuppressive therapy or steroid therapy. These, especially these patients with these symptoms, should be screened for TB. And I'm not going to the diagnostic methods of TB because we have a separate session on that. But what is a microbiologically confirmed TB? Whenever a patient with these symptoms or a presumptive TB patient from whom when a biological specimen came out to be positive for acid-fast bacilli or positive for TB in culture or positive for TB through rapid diagnostic molecular test, such patients are called microbiologically confirmed TB. What is a clinically diagnosed TB? In a presumptive TB patient who is not microbiologically confirmed, that is those tests which is required for the microbiological confirmation. If for any reason we are not able to get the sample or we are not able to do the test, but the patient is clinically fit into the diagnosis of TB, that is on the basis of radiological abnormalities, histopathology or clinical signs, and there is a decision to treat the patient with a full course of anti-TB treatment. Such patients are called clinically diagnosed TB. Now, based on the anatomical site of disease, TB can be divided into pulmonary TB and extrapulmonary TB. Pulmonary TB is the most common. It comprises of about 80 to 85% of cases. Pulmonary TB includes TB of lung parenchyma or the tracheobronchial tree. Extrapulmonary TB refers to involving organs other than the lungs, which involves pleura, lymph nodes, intestine, genitourinary tract, bones and joints, meninges of brain, etc. And this extrapulmonary TB constitutes about 50 to 20% of total TB cases. A patient with both pulmonary and extrapulmonary TB should be classified as a case of pulmonary TB. Now, what is the importance of classifying into pulmonary and extrapulmonary TB? We know the infectious form of TB, it is mainly the pulmonary TB. This pulmonary TB mainly spread through the droplet infection. Another form of extrapulmonary TB which can spread through droplet infection is laryngeal TB. Usually the extrapulmonary TB, if there is no active pulmonary lesion, they are usually non-infectious. Now, the classification based on previous TB treatment. Who is a new TB patient? A TB patient who has never taken treatment or who has taken treatment for less than 1 month. They are classified as a new TB patient. A previously TB treated patient is the one who has received more than 1 month of TB therapy or who have received ATT in the past. A recurrent TB patient is the one who has previously declared as treatment successful. That is, he or she has taken treatment for the prescribed duration. Microbiologically, he or she was declared as cured and found to be microbiologically confirmed TB again. This is called a recurrent TB patient. And what is the treatment after loss to follow-up? A patient is declared as loss to follow-up if the patient, while on ATT, was not taking ATT for a duration of 1 month. If the patient failed to take ATT for a duration of 1 month, then he is termed as loss to follow-up. So for all the TB patients, they should be referred for universal drug sensitivity test. Regarding the universal drug sensitivity, there is a separate session on that. Now, what is the risk of infection and developing disease? So a smear positive pulmonary TB case, that is a patient whose sputum sample is positive for TB. He or she can infect about 10 to 15 other persons in a year. And that patient will remain infectious for 2 to 3 years if left untreated. The lifetime risk of developing disease among those infected with TB is 10 to 15%. So what is the difference between infection and developing disease? Our body has an inherent mechanism to contain the TB infection. So those patients who are IGRA or MANDU positive, they may be infected with TB, but may not have an active disease. So a positive MANDU or IGRA may not be an indication for treatment in all patients. And the risk of developing disease is more in those who is co-infected with HIV or who has other determinants like poorly controlled diabetes, who has smoking tobacco products, alcohol abuse, or malnourished, or on immunosuppression or treatment for malignancy, etc. So coming to the treatment of TB. Now, under the National Tuberculosis Elimination Program, we have the fixed dose combinations for treatment of drug-sensitive TB. The fixed dose, they have active ingredients in fixed doses. So under NTEP for adults, there is 4 FDC and 3 FDC tablets available. So why fixed dose combination? The advantages include simplicity of treatment, increased patient acceptance because they have to swallow fewer tablets, increased health worker compliance because they have less tablets to handle, easier drug management, and it reduces the risk of monotherapy and lower the risk of emergence of drug resistance. So the TB treatment, it has mainly 2 phases. Anyone, can you just tell me what is the duration of treatment for a drug-sensitive TB? Any idea?
We have a few chocolates for those who are currently, but only RN. What is the value? It only lasts the duration of any 1%.
So usually the treatment is of 6 months. So we have 2 phases, the intensive phase and the continuation phase. So during the intensive phase, it is mainly for the rapid stop to bacterial multiplication. So the intensive phase is mainly with 4 drugs, that is isoniazid, rifampicin, ethambutol, and pyrazinamide. And continuation phase is for another 4 months. It is to ensure elimination of persisters, those inactive bacteria which can lead to relapse. So it is mainly for 4 months. Here it is mainly by using 3 drugs, that is isoniazid, rifampicin, and ethambutol. So the treatment regimen is in a new and previously treated cases which are sensitive to both isoniazid and rifampicin. We have the intensive phase for 56 doses. So that is HRZD, that is isoniazid, rifampicin, pyrazinamide, and ethambutol, and 112 doses of HRE, that is 4 months. Now, these are the dosages for first line ATT drugs. For isoniazid, it is 10 mg per kg, rifampicin is 15, pyrazinamide is 35, and ethambutol is 20. So we have the various weight bands, and based upon the weight bands, we will be giving the FDC tablets. So one FDC tablet will be having this combination, that is 75 mg of isoniazid, 150 mg of rifampicin, 400 mg of pyrazinamide, and 275 mg of ethambutol. So based on this weight band, the patients will be given tablets in the intensive phase and the continuation phase. Now, you might have seen along with ATT, these patients will be prescribed with pyridoxine tablet. What is pyridoxine? Any idea? So it is vitamin B6. In order, these isoniazid can cause peripheral neuropathy. So pyridoxine is prescribed to tackle peripheral neuropathy, and especially in those patients who are alcoholics, who are malnourished, pregnant and lactating women, patients with conditions such as chronic renal failure and diabetes, and with coexisting HIV infection. These patients are more prone to peripheral neuropathy with isoniazid. And these are the various adverse reactions to ATT. So initially whenever a patient is started on ATT, it will take few days for the patients to tolerate the ATT. So the initial counseling of the patient is very important. There you people have got a very good role. You should counsel the patients regarding the need for the treatment, why you should be treated. There you should be able to explain the spread of disease, how it is being spread, what is the need for treatment, what is the total duration of treatment, what is the need for the total long-term treatment. Many of the times what happens is patient will be asymptomatic after taking treatment for about 2 weeks, 3 weeks, and the patient will come back to you telling, I'm perfectly fine, should I take treatment? Then you'll have to explain to the patient that we have to prevent the relapse and spread of the TB. So complete treatment is essential for at least 6 months. And they will come to you with addressing various adverse effects. Like it can be mild adverse effects like pruritus, anorexia, nausea, or numbness, tinnitus, etc. And they can have more severe adverse effects in the form of hepatitis, cutaneous hypersensitivity, peripheral neuropathy, etc. So during these situations, you should be able to refer the patients to the physician, and he or she should be counseled sufficiently enough so that they won't stop the treatment in between. They will take necessary medical care and they will continue the therapy. So before starting the treatment, what all you have to do? We have the initial clinical evaluation include recording of weight, height, BMI for treatment initiation. Because as I have shown already, the treatment is weight-based. There is specific weight bands and we are providing tablets as per the weight. The assessment of nutritional status and linking the patient for nutritional support is very important, because nutrition also play an important role in controlling TB, and also it helps in preventing transmission. And we have to also take care of the comorbidities like HIV, diabetes, liver or renal diseases, and neurological disorders. And if there is any history of substance use, especially tobacco and alcohol, they should be counseled and sent to the cessation clinic or de-addiction center. And regarding the universal drug susceptibility testing, all TB patients should be offered rapid drug sensitivity testing for at least rifampicin, and further drug sensitivity for at least fluoroquinolones for all TB patients with rifampicin resistance, preferably before initiation of treatment within 15 days of diagnosis, because this is mainly done to find out MDR patients at the earliest. Efforts must be made to for all these patients, TB patients, if a suitable sample is available, and including extrapulmonary TB, all efforts should be made to do drug sensitivity testing. And counseling of patient and family members is equally important, because education about type and mode of spread of disease, dosage schedule, duration of treatment, common side effects, and methods to prevent, these all should be well explained and conveyed to the patient and family members. Importance of regular treatment and consequences of irregular treatment or premature cessation of treatment should be well explained to the patient and family. The risk of relapse, the risk of multi-drug resistant TB, the risk of morbidity and mortality if not treated fully, all these should be explained to the family. Also, the risk of family members at home getting infected with TB, all these should be well explained to the patient and family. treatment adherence should be ensured. An explanation about cough etiquette and proper disposal of sputum for prevention of transmission is also important. And encouragement to get all close contacts, especially at home, to be screened for TB at the earliest. And assurance of support during the entire course of treatment by the medical officer and peripheral health workers should be ensured. And regarding the follow-up of treatment, so at least monthly follow-up by the medical officer for improvement of clinical symptoms, increase in weight, control of comorbid condition, and presence of ADR should be done. And the laboratory follow-up at the end of intensive phase at the end of treatment and whenever indicated. So the sputum culture is done at the end of IP and end of treatment, and a chest X-ray is advised for clinically diagnosed cases and for some extrapulmonary cases and in children. And long-term follow-up after completion of treatment, every 6 monthly for 2 years, the patient is followed up. This is to identify early relapse and to initiate treatment if required, and thereby to prevent spread of TB. Now, coming to the drug-resistant TB. So as already mentioned by Alok sir, drug-resistant TB is those TB which is not sensitive to the usual first-line medications, especially isoniazid and rifampicin. So we have isoniazid-resistant TB. Here, the tuberculous bacilli will be resistant to isoniazid. And in monoresistant TB, a patient whose biological specimen is resistant to any one of the first-line TB drugs, that is isoniazid, rifampicin, paracetamol, or ethambutol. Polydrug resistant is whose biological specimen is resistant to more than one first-line anti-TB drug other than H and R, that is isoniazid and rifampicin. We have rifampicin-resistant TB. In CBNAT test, we are looking for the sensitivity of rifampicin. Rifampicin-resistant TB is the one which is resistant to rifampicin. So, multi-drug and pre-extensively drug resistant, which is already mentioned by sir. So, in MDR TB, what we have to understand is we have a programmatic management for the treatment of MDR TB. So, these patients should be sent to the specified DRTB centers for their treatment. They will undergo proper pre-treatment evaluation, and based on the clinical profile of the patient, they will be started on the various MDR TB regimens. Nowadays, we have all oral drug regimens for these patients. So MDR TB, they can be treated and they can be controlled. So your aim is to send the patient to the designated MDR TB centers for the treatment. Thank you.